We're now going to talk about hypoglycemia, low levels of sugar in the blood. Now, when your blood sugar level starts dropping, you might start feeling a bit shaky and a bit hungry, anywhere below about 4 millimoles of glucose per litre of blood. The pathologists tend to define hypoglycemia as a blood sugar of less than 2.5. But remember, we've said before, when managing diabetes, we don't really want the blood sugar to go below 4, precisely because of this risk of hypoglycemia, because 4 is the floor. But 2.5 or below would definitely be a hypoglycemia. And for most patients, it depends if they're used to running low blood sugar levels or not, but for most patients, they would become unconscious at around about 1 millimole of glucose. So anything less than that would result in unconsciousness in the acute situation. Now, I think first of all, just before we talk about hypoglycemia in diabetics, we'll mention hypoglycemia in non-diabetic patients, because children and babies are prone to hypoglycemia if they are ill. If you think about it, if the body is ill and having to fight infection and generate pyrexias, it's using a lot of energy up. And remember that when you were 6 months old, you only had 500 mils of blood, so the amount of glucose in the blood in total is going to be way less than it is in the 5 or more litres of blood that you might have in your adult circulation. So poorly children can become hypoglycemic, and this needs to be observed for and managed appropriately, of course, if it develops. In children with diarrhea and vomiting, for example, these still tragically the most common cause of death in children in the world under the age of probably 5. Obviously, hypovolemia and electrolyte imbalance are going to be the main problem. But after that, hypoglycemia can be a cause of death. You get rare endocrine conditions as well where the patient becomes hypoglycemic. An insulinoma, for example, will be a tumour of the beta cells. But I'm sure you've all experienced low blood sugar levels. Maybe you've been cycling or walking or running or swimming for a period of time and you haven't had access to food, and you start feeling really hungry and really shaky. That is hypoglycemia. And the clinical features actually depend to some extent on the degree at how quickly the blood sugar levels fall. But before we do that, let's look at the causes. Let's be clear about the causes. Hypoglycemia is caused by several things, possibly. Too much insulin is probably the most common one you're going to come across. And this is insulin which is given in disproportionate amounts to the amount of carbohydrate that the patient has been eating. So, for example, we might simply make a mistake and give too much insulin. We might simply get it wrong. Hopefully not, but mistakes do happen and patients can be given too much insulin. If this does happen, it is a life-threatening condition. We have to be honest about it, and we have to treat the condition appropriately. Or insulin might be given in the anticipation that the patient is going to have a meal, and then the patient feels sick and doesn't eat it. Or the meal might be eaten and then the patient vomits. So again, they've got the insulin on board, but they haven't got the food to compensate for the insulin. Vigorous exercise, of course, is going to work in the same way as insulin by lowering blood sugar levels. The exercise is going to use up the sugars, and vigorous exercise can result in low blood sugar levels. Alcohol is also a hypoglycemic agent. People who've drank alcohol will eat all sorts of things that they might not normally eat, partly because they're disinhibited due to the effect of the alcohol, of course, but also because the alcohol has dropped their blood sugar levels. It's made them relatively hypoglycemic, and this stimulates the appetite centre in the hypothalamus and causes eating behaviour. Infections are another possible cause of hypoglycemia. Now, patients with infections, the blood sugar can actually go either way. There can be a stress response which increases blood sugar levels, but alternatively the blood sugar levels can drop because the body needs to generate a pyrexia, because remember the body's immune system works best at pyrexial temperatures. So if someone has an infection, the body will generate a pyrexia, and that takes a lot of energy to heat up 70 or 80 kilograms of body, even by 1 or 2 degrees centigrade. Takes a lot of energy, and that can lower blood sugar levels. So the rate of onset of hypoglycemia will depend on the cause. If it's too much insulin, then normally insulin given subcutaneously starts taking effect after about 15 to 20 minutes. Or of course it might be slower if it's one of the longer acting insulins. 10, 15, 20 minutes for the soluble actrapid type of insulin, and we can expect the onset of features. Now there's two groups of clinical features present. Two causes really of clinical features. And the first one is that the first group of features are caused by the release of the catecholamines from the adrenal medulla, the adrenaline particularly. So when blood sugar levels fall, adrenaline is released because adrenaline will increase blood sugar levels. So the body's trying to compensate for the acute hypoglycemia by releasing adrenaline. It will also release glucagon as well, but adrenaline particularly. So some of the signs and symptoms are from the release of adrenaline and the way it affects the nervous system when the blood sugar falls rapidly. So there might be nervousness and feelings of anxiety because of the release of adrenaline. And the classical features we associate with hypoglycemia are caused by the adrenaline, the tremor, the shakiness in the fingers, the tachycardia, the palpitations that the patient can report, the pallor, the paleness, and the sweating. These are all caused by the stimulation of the sympathetic nervous system by adrenaline, which the body releases to try and bring the blood sugar levels back up. And the other group of symptoms are caused by depression of the central nervous system, because it's the central nervous system that's affected first when the blood sugar level falls. So the patients might complain of headache or lightheadedness or confusion. There can be emotional changes or even inappropriate behaviour. Sexual or aggressive behaviour can occur. There can be slurred speech and poor memory, poor coordination, staggering, drowsiness. Eventually, of course, there'll be coma and possible convulsions. The trouble is, all of these features, of course, are very much like drunkenness, really. In drunkenness, when someone's drank alcohol, the central nervous system, the cerebral cortex, isn't working properly because it's being depressed by the presence of the alcohol. And in hypoglycemia, the function of the cerebral cortex is being depressed by the hypoglycemia. So they can appear to be similar. And hypoglycemia, remember, is a life-threatening condition. It is a life-threatening condition. Indeed, tragically, when doctors and nurses kill themselves, very often they choose to induce hypoglycemia. They inject themselves with insulin. So we need to look after our colleagues and make sure that they're not becoming depressed, because we do work in a stressful environment. It is difficult, the clinical environment. Right, what the heck do we do about it? What is the treatment of hypoglycemia? Well, obviously, if the patient is conscious, we simply give them some sugar to eat. Simple as that. And then once we've got the blood sugar back up to reasonable levels, then it's best if we give them a complex carbohydrate, because with a low glycemic index, that will maintain blood sugar levels over a long period of time. But in the short term, get any sugar you can into them. Chocolate, fizzy drinks, sweet fizzy drinks. Just be careful you don't give the no-calorie type fizzy drinks, because they don't have any sugar in them. But anything that gets sugar into your patient is good. After that, complex carbohydrates, and keep the sugar up for a long period for a period of time after that. Now, if the patient is unconscious it gets more difficult. In the first aid situation, what we can do is we can actually smear hypostops or simply treacle or syrup or sweet jams around the inside of the patient's mouth. Now, I know this is associated with a risk of aspiration. Obviously, we don't give them anything to eat or drink to swallow, but quite a lot of sugar can actually be absorbed through the mucous membranes of the mouth. Failing that, in the hospital situation, what we would normally do is give, you can give intramuscular glucagon. That can be quite effective because the glucagon will increase blood sugar levels. But in hospital, what we normally do is just run in some intravenous glucose or dextrose, some intravenous sugar solution. Traditionally, we've used 50% dextrose, but that can be quite harsh on veins actually, so you might get away with a lower percentage than that, 20 or 30% dextrose. But if we're giving IV glucose, if you give 50 mils of 50%, that might be enough to wake the patient up. And then, of course, once the patient is awake, then you can give them something to eat. So you only need enough intravenous glucose or dextrose to waken them up and then just give them something to eat. And patient, I think final thing to say is patients should carry med alert cards so that if we find someone who's unconscious, we look in their wallet, or something dangling around their neck or a bracelet on their wrist. We find they've got a card saying they're diabetic, then that's very useful for us because it indicates how we might treat them. We could do a BM test, find out the hypoglycemic, and treat them accordingly. Early treatment, the patient should recover completely. Without treatment, remember, this is a life-threatening condition. Has to be taken seriously.